Welcome to this, the third in a series of webinars brought to you by the European Institute of Health and Sustainable Development, known as the EIHSD, whose mission it is to find Europe-wide solutions to healthcare problems. And as you can imagine, we've had quite a few of those over the last year. My name is Joe Lynham, and I present a program on the BBC World Service called The Newsroom. And before that, I was a business correspondent and presenter for many years. I hope all of you and your family are well and that you have avoided this awful virus that has devastated not just Europe, but the whole world and continues to devastate the world, including Brazil and India. What this crisis has done is highlight the importance of healthcare and healthcare policy throughout the world, especially in Europe. And only last week, the German Chancellor, Angela Merkel, was saying that if European Union wants to introduce a health union, then the treaties could and should be amended. So that is a very important statement from the most important country in Europe. And we hopefully will be discussing that issue, which has certainly preoccupied the minds of us here on the EIHSD. Today's third seminar is titled Modelling of Pull and Push Factors of Healthcare Workforce Mobility, taking into account the impact of the COVID-19 pandemic. It will build on the Institute's previous developed findings, which include actual statistics of migration and the legal regulation of healthcare mobility within the EU. The emphasis of this third seminar will be on modelling, both qualitative and quantitative, and the push and pull factors for the mobility of healthcare workers, taking into account, of course, the huge impact that COVID-19 has had on all our lives. We'll be speaking to some of the key stakeholders and thinkers in Europe's healthcare sector, whether the industry has the right skills or manpower in the right places to ensure the goal of universal healthcare, and we'll be discussing how COVID-19 has impacted. In a moment, I'll be calling up the former EU Health Commissioner Vytenis Andriukaitis, who is now the chairman of the EIHSD. After Vytenis, we'll have two panels. The first panel will feature Sergejus Glovatskas from the International Labour Organization in Geneva, and I believe that tomorrow and today are two big days for the ILO, and I'm sure Sergejus will tell us more about it. Then in the second session, we'll bring in Ruthie Kaider, who is a director with the software giant Microsoft, about working from home. Then we'll have Dr. Markus Schneider from the Research Institute Basis in Augsburg to continue his qualitative analysis of the migration of people from less well-off European countries to receiving nations, often in Western Europe. Then we will have Dr. Birute Tumieni from Vilnius University, also known as Santaros Clinic, and all the biographies and CVs, and these guys are very qualified, ladies and gents. They are super qualified. You can see it on the website, which is eihsd.eu/news. After we've heard from all our experts, we're going to open it up to you out there to share your views, your questions, your thoughts. Please use this opportunity with very high-profile guests to pose a few questions. Say who you are and who you'd like to ask a question for. I'm sure after the last year of lockdowns, you all know how to use Teams. If you want to pose a question on the right-hand side, you will see the option for posing your question. And if we have time, I will put them to our panel. There will be simultaneous translation and subtitles in 6 languages, no less. So we will be chatting in English, but there will be translation in German, French, Russian, Latvian, Polish, and of course, Indian. So please go to the settings wheel, the little kind of engineering wheel on the bottom right of your screen at the moment. Have a look at captions and languages and make your adjustment if you want to see the text on your screen. The hashtag, if you're a tweeter or a social media fiend, is hashtag sustainable development, all one word, obviously. Hashtag sustainable development. Everything's on the record, so please be nice. Before all of that, I want you to have a look at the video from our last session, which, just to refresh a lot of your memories, some of you will have been there, of course. In that second in our series from EIHSD, we looked at suboptimal allocation of the healthcare workforce in EU member states and the phenomenon of medical deserts in Europe. Start thinking of your questions for our panel while you do. And if you could roll the tape there out to us, we'll have a look at what we did the last time. Stay with us.
Growth of international migration and mobility of medical professionals in the EU is a development that provides benefits, but at the same time, it is not immune to risks. The free movement of people is cornerstone of an open and integrated EU and has to be cherished. Immigration of highly educated workers places a strain on countries of origin. WHO Global Code of Practice on the International Recruitment of Health Personnel is calling for the need to balance interests of all parties. The first objective of the code is to establish and promote voluntary, may I draw attention, voluntary principles and practices for the ethical international recruitment of health personnel, taking into account the rights, obligations, and expectations of source countries, destination countries, and migrant health personnel. Article 5 of the code says that the health system of both source and destination countries should derive benefits from the international migration of health personnel. The code presents the European Union with a paradox. The EU and its members are clearly committed to the code's principles outside the EU, but in the EU, free mobility is legally binding and may not be hindered by governments or other actors. Questioning how to strike a balance between strengths and weakness of migration and mobility of medical professionals and to assure optimal allocation of health personnel in member states is fundamental for global, European, and national health policies. How to assure equilibrium between freedom of movement for healthcare workforce and such objectives of the EU as cohesion between regions, acceptability of services, and universal health coverage for all Europeans. Of course, we need to think about possibilities to amend Lisbon Treaty. Today's Lisbon Treaty is not capable to deliver issues related to social fairness and social inclusion. Let us amend article which starts with the Union shall establish an internal market by one sentence. It shall promote universal health coverage by establishing a health union.
We need to improve health work policies and decrease reliance on foreign trained health professionals. It's a domestic task. Countries need to get their act together and need to see that they recruit as much as possible from their own resources. It will differ from country to country. Some are small, some are poor, and so on. But we need to see that mainly we resource ourselves from our own sources. Second, we really need to improve monitoring. We need to have better country coverage. Forecasting and planning, we need to do this on the European level. We have a European labour market, but we need to know what's in the training pipeline. What are the workforce policies? Where do we want countries to expand? Where do they want to cut back? And we need to understand the skill mix. From OECD data, we know that many health workers in OECD either feel they are overqualified or underqualified. We know studies that there's a lack in digital health. At the same time, we are allowing all these under or overskilled or misskilled health workers to go to another country to work with under or overskilled workers. So we need to get continuous training, medical training, professional development really on the agenda Europe-wide, in particular for integrated care, which is more complex, and in particular for digital health.
Offers a possibility for source states to restrict the number of healthcare professionals moving to another member state by arguing that it would be necessary to prevent a shortage of healthcare professionals available for the own population. But I must disappoint you, that is not possible. Free movement of workers is different in that respect, in that European legislation has limited the possibility to invoke public health for restrictions of exit. Furthermore, there is a provision in the EU Charter of Fundamental Rights that specifically grants every citizen of the Union the freedom to seek employment and to work in any member state. So outright restrictions are not possible. So the message here clearly is solve the problems with rules that promote free movement, no rules that block free movement. I could think of 2 suggestions, but none of these would provide a sustainable solution. The first is, and this refers a bit back to what was said before, access to higher education should be linked to certain conditions, or could maybe link to certain conditions, such as work in the member state where one enjoyed higher education for, let's say, at least 1 year. Now, as you may conclude from these suggestions, I think the current free movement provisions do not offer many possibilities to address a disbalance of healthcare workers in the European Union. I think solutions must be found outside free movement law. One could also consider the introduction of a solidarity principle that accompanies free movement. And it would entail a fiscal transfer from rich receiving states to source states. So let's say a compensation for higher education, similar to the compensation we have in the transfer system in football. And finally, it would be good to combine local, national, and EU measures. And at the EU level, the cohesion policy seems fit for this aim, because the fact that entire generations of doctors and nurses leave for other member states after they received an expensive education from their home state is directly going against the intention of EU cohesion policy.
The strategies that have been developed may rely on education, financial incentives, regulation and coercion, or professional and personal support. Of course, they can combine these different policies. And I would like to say that for me, the first responsibility is really to train enough professionals to meet the national population needs. And I just like to show the example of France on this graph, that the fact that the training capacity implies more or less migration from other countries. How to strengthen these responsibilities? So the first thing might be to increase public awareness of these issues in each country, because to be honest, in France, we don't have that much public debate about that. The income is better in Western Europe, and so it's very difficult to retain locally trained medical staff. When you see all this research about preferences of doctors and other professionals, you show that the value attached to non-monetary incentives is very high, but doesn't work perfectly well, but work little, which is financial help for students linked to some sort of service agreement, but together with all these recruitment strategies and support. That is a combined strategy with making these newly registered practitioners happy to be where they are with a good work environment, and being, of course, supported in their studies as well. It might be also maybe a way to retain more professionals within each country.
And our mission statement was to improve healthcare in countries of transition. The program should promote brain gain and prevent brain drain. At the same time, providing state-of-the-art postgraduate medical education and training to young, dedicated physicians, empower healthcare professionals, and give them the opportunity to rebuild the healthcare system. And why was this necessary? We offer only short-term fellowships, multiple opportunities. We had a clinical focus from the very beginning, and I would consider this as high-level mentoring. That's at least what we wanted to achieve, and that apparently led to brain gain. Now, after 20 years, since this program is now up and running, you can see that 23,000 or almost 24,000 people participate in the seminars. 3,400 fellowships were given out for observerships. I mentioned already 268 satellite symposia. So the program has an impact at the healthcare in these countries, because most of our physicians not only went home, they stayed home. That only more than 90% of our fellows are still practicing medicine back home.
International organizations and health workforce, ILO, EU, WHO regulations opening gates for free movement of health workers and for deepening of health workers shortages in the sending countries. The failures of these push and pull factors could be hard to implement because sending countries often are lower income countries and cannot compete with high income destination countries for health workforce. The pull factors often induce the redistribution of health workforce inside state territory, but not the factor which impede migration. Greater self-sufficiency through increased domestic education and training capacity by receiving countries. This proposal has some shortcomings. For destination countries there is still cheaper to import than to educate health workforce themselves. Having in mind limitations of implementation mentioned measures on national or bilateral multilateral levels, we fully agree with the statement that taxpayers in sending countries have a right to reimbursement for their investment in training health workers who migrate out of the country. There are few proposals on compensation for sending countries, resource transfers from destination to sending countries, for example, through investments in the training systems of those countries from which destination countries draw staff.
Thank you very much for all our participants last time in the second webinar in the series. Matthias Wismar, Annette Schrauen, Dominique Polton, Wolfgang Aulitzky and Algis Dobrovolskas. And welcome back to this one. And I'm going to go straight now to the chairman of the EIHSD, Dr. Vytenis Andriukaitis, for his presentation entitled 2021, the Year of Health and Care Workers, What Evidence-Based Lessons Can We Learn from the Pandemic? If you can proceed there, Vytenis, the floor is yours.
Thank you, Joe. Dear colleagues, ladies and gentlemen. Before the start of our event, let me share an important news. Just a few days ago, Eurobarometer published a preliminary report on preferences of Europeans. Health always was a top priority for families. Today, health is a top priority of the European Union. May I ask to show my first slide? I have no doubt that European Health Union is a very right answer to this topic. Okay, you see that the health is now top priority. Congratulations, it's our common effort. This is the third webinar on healthcare workforce international mobility, looking at statistics of mobility, scope, source and destination countries, professional structure, most recent trends. Was the main purpose of the first webinar in February. Opportunities to manage the process of mobility on local, national, EU and global levels were looked through the second webinar. The conclusions reached so far are as follows. First, international mobility of medical personnel is growing. Wealthy OECD economies are mainly playing a role of destination, and developing economies plus economies of Central and Eastern Europe a role of source countries. Second, formal training of medical personnel is a main factor shaping supply of professionals globally and in long run nationally. Current surge of recruitment of foreign trained doctors by the developed world is, at least partially, based on a reduction of medical students numbers in countries affected by neoliberal thinking and cost containment policies of the 80s and 90s and austerity policies that damaged healthcare systems after the recession of 2007-2009. Reductions in public spendings on health following the financial crisis damaged health systems. Increased public investment in health is needed in most countries to make progress towards universal health coverage and to improve health, well-being, and protection from health emergencies. Relatively low income of medical professionals in developing countries and the European East are the main push factor of international mobility. Some experts see a convergence between the old and new states of the EU as a factor reducing opportunities to increase income by international mobility. The future will tell us how realistic this prediction is. European Union law prioritizes free movement of labor against public health objective-based regulation of the labor market. This reality favors positive incentives of retention implemented by the member states and at the same time limits the toolkits of restrictive national labor policies within the EU. The purpose of the current third webinar is to go beyond the above listed conclusions by looking into qualitative interrelationship of determinants of health care workforce mobility. The webinar coincides with a third wave of COVID-19 pandemic. Thus, speakers are asked to reflect the ongoing health emergency and its impact on healthcare personnel in short, medium, and long term. Some questions to the panel. What scope and professional structure of healthcare professional is best suited to withstand the disaster and assure resilience and efficiency of the health sector in the foreseeable future? Second, what technologies help medical professionals through the pandemic, and what practices caused by the pandemic are going to stay with us after face masks will disappear from European streets? Third, should medical universities return to businesses as usual immediately after the herd immunity is developed, or they have to look for deep transformation? And fourth, European leaders speak about equity and cohesion within the EU. COVID-19 increased a gap between strongest and weakest member states. Our EU, unfortunately, is an unequal one today. This is not only unfair, but is it preventable? What practical steps are needed to convince Europeans that European solidarity is a real thing, not just a lip service to appease the masses? While preparing for the webinar, we in Vilnius looked for clues why excess deaths differ across the EU member states in 2020. An increase of deaths in 2020 was compared with the number of hospital beds, doctors, and total healthcare personnel employed in the sector of human health. Please show slide. Correlation between total employment and in the health sector and excess mortality appeared to be strongest. The preliminary finding that health outcomes may be better understood by accounting efforts of the total healthcare workforce and not just those of doctors or doctors and nurses combined is important for development of health policy. A role of auxiliary, technical, managerial, and administrative personnel, as well as a role of informal carriers, deserves to be better documented and studied. Our webinar is one of international activities related to health workforce during the pandemic. The second round of the Global World Health Organization survey reveals that over 1 year into the COVID pandemic, substantial disruptions persist, with about 90% of countries still reporting one or more disruptions to essential health services. 66% of countries continue to report health workforce-related reasons as the most common cause of service disruptions. 2021 has been designated by WHO as an International Year of Health and Care Workers in appreciation and gratitude of their unwavering dedication in the fight against the COVID-19 pandemic. WHO is launching a year-long campaign under the theme Protect, Invest, Together. And World Health Day this year was dedicated to equity. Equity, very strong word. I'm in solidarity with the call that our health and care workforces are supported, protected, motivated, and equipped to deliver safe health care at all times, not only during COVID-19. I ask all participants of the webinar to add their voice to those calling for additional investments in health and care workers. COVID-19 created suffering for millions, but at the same time, it already mobilized collective global and European response. 2 years ago, discussions on European Health Union was unthinkable. Since September 2020, European Health Union is in the mainstream of the European Union politics. In May 2020, just a few dreamers dared to call for the stronger representation of health in European treaties. On the 21st of April 2021, German Chancellor Angela Merkel indicated that she does not rule out a treaty change. It is very timely and very welcome statement. We are living during difficult but interesting time. Let us start our webinar modeling of pull and push factors of health care workforce mobility, taking into account compact of COVID-19 pandemics, and the floor is open for all of us. Thank you.
Ačiū, Vytenis. Thank you for that. I'm glad to see you changed your tie from the previous video. That was nice. You've raised some important issues, some of the important questions you raised there. I'm going to keep them for our big panel discussion a little bit later. Stay with us, Vytenis, if you will. I'm going to ask you a question about those comments from Angela Merkel in a few moments. Just a quick reminder that you can submit your questions using the Teams function on the right-hand side. Submit your questions and tell us who you would like to address the questions to. The video you watched and the video for this live session will be put on the website, eihsd.eu/news. So you can see it all again. It's interesting statistical analysis there. Now let's discuss our first big issue now relating to workforce healthcare and hear from Sergejus Glovatskas. He's from the International Labour Organization, the ILO, and he works in the desk office for Europe and Central Asia, ILO in Geneva. Hope the weather's nice there. Sergejus, if you could unmute yourself, and you will talk about occupational health and safety for healthcare workers. Sergejus.
Good afternoon. So thank you very much for the invitation. It's a really pleasure to be with you and to greet you on behalf of Workers' Activities Bureau, ACTRAV, Activité du Travail, of International Labour Organization. As John introduced me, I'm desk officer for Europe and Central Asia. So in my responsibility, 52 countries, to work with trade unions and workers' organizations and healthcare workers and trade unions of healthcare system is a big part of this family, and we pay special attention to relation and to activities with healthcare workers. And as of course, as I would like to say thank you to Vytenis Andriukaitis for his nice introduction, and also that he so invited me to attend this fantastic and really important event. And I hope we will have also opportunities in the future to meet face to face and to discuss all these issues. So it's not occasional, I guess. Your event is today, and because today, so we start just a number of events related with occupation, health and safety. And also tomorrow, all international trade union movement and not only trade union movement will commemorate special day on memorial of workers died at workplace from accidents and professional diseases. And logo and main motto of this year day is occupation health. OSH, occupation health and safety should be a fundamental right and principle at work at workplace. I would like to remind what it is. In 1998, International Labour Conference adopted a declaration on fundamental principles and rights at workplace. It consists of 8 fundamental conventions: 2 conventions against child labor, 2 conventions against forced labor, 2 conventions against discrimination at workplace, and 2 conventions for freedom of association and collective bargaining. It means that these conventions, even if countries not ratified these conventions, but the fact of membership in International Labour Organization, the Statute of International Labour Organization asking to follow this. We had some cases, for example, last Convention 87 ratified by Uzbekistan 4 years ago, but anyway, Uzbekistan was obliged to report and to follow Convention 87. So in 2019, 2 years ago, it took place this anniversary conference of International Labour Organization, 100-year anniversary conference, and was adopted Declaration on Future of Work. So was described main directions of how labor will go in the future, and also main directions of work of International Labour Organization. And one of suggestion and proposal from the worker side was to enlarge fundamental declaration by special convention on occupation, health and safety. It means that occupation, health and safety to work decent conditions and safe conditions and healthy conditions is fundamental right and principle. So ILO has adopted a number of conventions on occupation, health and safety, and it says a number of conventions in relation with healthcare workers or nursing personnel and so. And also some convention on migrant workers. Now, because you discuss mobility, Convention 97143, but not all countries ratified, and not not so many sometimes tools how to promote it. But with this enlarging of fundamental declaration, it will be a very strong, I can say, tool and perspective to promote occupation, health and safety. Just so a few words about healthcare workers. International Trade Union Confederation just disseminated a statement on this Occupation Health and Safety Day, and also on Workers' Memorial Day, with some quite, I can say, concerned statistic. Just I will share it with you. I will share it with in chat. So I try with you. Link. Oh no. Okay, I will send to Audrey Martinkus everything, all my presentation. So every half an hour, one healthcare workers die from COVID-19. You can imagine that during our webinar, which will take 2 hours, 4 healthcare workers will die from COVID-19. Every day, 7,600 workers dies from occupation, so accident of workplace and professional disease. And such statistic, of course, it's not so good when it's 21st century and such high achievement of civilization and new technologies and so, but it's no any war or military conflict or so, they're not taking so many lives like occupational accidents at workplace and occupational diseases. Second, what is connected with today our discussion, after pandemic started, it's now a lot of proposals from different groups of workers, from healthcare workers, about recognition COVID-19 as professional disease. So, and it means both benefits and profit, but it's different country discussing, and we have some good examples on collective bargaining, social dialogue in this sphere, but also it's so now we receive a number of requests that we need some international labor standard in this sphere, not about COVID, maybe some about international labor standard about biological treats or disease or something like it, and discussion started. Let's see how it works. But so we cooperate very close with World Health Organization, and as you know, so first building is World Health Organization, second ILO, and we are sharing this crisis because now the main burden is on the World Health Organization, how to stop, and so and recovery will start, and labor places and of new jobs, and of course on the International Labour Organization, also it will be a big task. And one our General Director Guy Ryder announced that we are now thinking about not back to normal, but back to better normal. So the world should not be like it was before. So in February, International Labour Organization and World Health Organization prepared and distributed interim guidance, COVID-19, occupational health and safety for health workers. And just I will mention main key points. Health workers should continue to enjoy the right to decent, healthy and safe working conditions in the context of COVID-19. Primary prevention of COVID-19 among health workers should be based on risk assessment and introduction of appropriate measures. Other occupational risk amplified by the COVID-19 pandemic, including violence, harassment, stigma, discrimination, heavy workload, and prolonged use of personal protective equipment should be addressed. Occupation health service, mental health and psychosocial support, adequate sanitation, hygiene, and rest facilities should be provided to all health workers. Healthcare facilities should have occupational health programs in conjunction with programs for infection prevention and control. Employers have the overall responsibility to ensure that all necessary preventive and protective measures are taken to minimize occupational risk to health workers. Health workers are responsible for following established rules for the protection of their health and safety of the work. So I will share all this paper, and so that I hope that you can use it in health workers in your daily life. And just before to finish, I want to add a few words about our cooperation with health care workers, trade unions, international organization. As you know, it's Public Service International, and on European level, EPSU, European Public Service Union. We have a number of programs, and we provide consultative, methodical, and assistance for most suffered countries and unions in Europe. In ILO case, we have our regional division, Europe and Central Asia. Central Asia and this, countries like Kazakhstan, Turkmenistan, Uzbekistan, Tajikistan is under responsibility of European desk. So we provide some special assistance, special programs, and in cooperation with also International Healthcare Workers Organization. And on migration, we also now paying as the most suffered part of employees and workers are workers migrants. And we providing special assistance and support and some bilateral programs, for example, Lithuania, Ukraine, also Central Asian countries, South Caucasus countries like Armenia and Azerbaijan with Russian Federation, because the biggest flow, by the way, Russian Federation is number 3 in the world receiving country of migrants, and it's a lot of doctors and nurses from Tajikistan, Kyrgyzstan, Uzbekistan working in Russian Federation, and the same is now with from South Caucasus to Europe, from South Caucasus, Ukraine, and Moldova to European Union. I'm so happy to be with you. And so now I will share the materials. I'm sorry for a little bit spontaneous and chaotic presentation, but it's very extremely important topic, and I really appreciate and thank you that you invited me. Thank you.
Thank you very much, Sergeyos, for your thoughts. I took note of some of the conventions that the ILO has, and I will come back to you with my own questions as well as questions from the audience. Don't forget to start posting your questions to our panel. I will come to Ruthie Kaider from Microsoft shortly, but I want to come back to the chairman of the EIHSD, Vytenis Andriukaitis. You made reference to comments from Chancellor Angela Merkel last week regarding health union. Now, if the treaties are reopened, that could cause major problems for smaller countries that need a referendum. And I know from my own homeland of Ireland that they would need a referendum if any European Union treaty was reopened. They may say, actually, we're going to vote on what we think of the current government, rather than think into the future about healthcare and a healthcare union. Vytenis, you're muted.
Now, you know, it is always very important issue. I remember our time when we prepared to European Union treaty establishing a constitution for Europe, and then two referenda in the Netherlands and in France rejected such brilliant job, but referendum in Spain was in favor. And if you combine those three referenda, you can see that Europeans were in favor of the treaty because common figures show that most pan-European approach was, more encouraged to see future progress. Now, when we are speaking about changes in the treaty, of course, we need to have communication strategy, information campaign, debates. We can open debates publicly because we need to hear people's voice. Now, like never, it's important to invite all people to discuss. And can you imagine how is close to people's hearts topic of health? I have no doubt that people in Ireland are very worried about their health, for sure. Eurobarometer shows that you have now health as a main priority between Europeans. It's excellent news, brilliant. Let's be brave. Let's discuss. Let's deliver to people to say their yes or no about European health. It's not Brussels-based project. It's not institutional-based project. It's not bureaucracy-based project. It should be based on people. And health is so understandable for all people. Please ask people about European banking union or European, digital market or something. They are far from those problems. Sometimes European Union looks like very old, old-fashioned actor. But health is very important, very new one. And now it's around in all corners. I strongly believe that we need to open public debates. We need to encourage our people to think about, because now, like never, it's important to strengthen our European Union, especially keeping our conditions, well-being of people and health of people. I am proud. I am in favor about debates, and I'm ready to facilitate and to discuss those issues and encourage people to organize referenda, because it will be so excellent, brilliant time for Europeans.
Well, if we could bottle your energy and your enthusiasm, former Commissioner Andriukaitis, I think we would have the solution very easily. You're absolutely right. People are focused on healthcare now, but there is the risk, of course, that they won't be in 5 years' time. But let's move on. Thank you for your intervention there. Stay with us, please, Vytenis, and we'll come back to you at the end with the panel discussion. Let's move on to our second big question, and we have a special treat for you. We're proud to be joined by Ruthie Kaider from Microsoft, who will tell us about her giant organization, how it handled the pandemic, and the instant switch to working from home for tens of thousands of its staff. And as for the more astute of you will have noticed that I am reporting from my home office, or shed, as my kids call it, which I've had to transform over the last year. And I'm sure for tens of thousands of Ruthie's colleagues in Microsoft, that has been the case. Ruthie is the director for the health industry sector for Central and Eastern Europe with Microsoft. And Ruthie has to rush off afterwards, so I will put a question to you after your presentation, if I may, Ruthie. But for now, the floor is yours.
Thank you very much, Joe, and very, very honored to be here. Thank you for the invitation. What I want to talk about today is two things. Exactly what Joe said about how Microsoft moved to work from home and how we manage our business in that way across the world, and also our view and how we've been implementing and leveraging our digital tools to help our customers deal with their challenges, especially around their healthcare workers and health and care team collaboration to really better serve patients today. So honestly, I mean, as somebody I'll start with the second, and I'll start with our mission, because I think that's really important, because everything we do that's our North Star. So the Microsoft mission is to empower every person and every organization on the planet to achieve more. And as I mentioned, this is really the North Star in everything we do, whether it's how we treat our employees and look out for their mental health and for work-life balance, and to make sure that they are able to both work, but most importantly care for their families, and also how we work with our customers and our partners, and how we bring our products to life. If we look at healthcare trends, and exactly what Vytenis mentioned, we see a huge trend of consumerization of healthcare. So patients expect the health institution to have full access to their medical history, but also they want the 360-degree view. And honestly, healthcare organizations want the patients to be more accountable for their health as well. So that consumerization, that patient in the middle, that person that in the middle, is something that we are seeing as a trend, and I honestly very much agree with that. Another trend we see is around data. And, if you talk about the healthcare workers and what we need from healthcare workers, they're going to have to be able to deal with data, huge amounts of data. Most of this data is siloed and unstructured today, but once we, one of the biggest challenges to bring that data together. But once we bring that data together, that's when we can use predictive analytics, decision support systems, AI, artificial intelligence to enhance the care workers, the administrative workers, the operational workers, to be able to be more efficient in their work. 30%, if not 40% of healthcare workers' time is spent on administrative work. And if we can automate that, and we can make their work more efficient using analysis and trends and visualization, they can spend more time with patients. And then another trend I want to talk about is exactly what we're talking about here, is around healthcare workers. So as the populations age and as the healthcare needs become more complex, most health providers and hospitals are really facing that global shortage of workers that we're talking about. And of course, it's coming at the worst time possible. So, and by 2030, we expect providers to suffer from a projected shortage of 14 million workers worldwide, which is huge. So if you look at the new vision of healthcare, as we see it from working with thousands of customers already all over the world, it's that gaining that holistic view of the patient, increasing the number of patients served while maintaining the high quality and high touch interactions, visualizing health trends and outcomes. That will also add to the efficiency and to the speed of care, and to the knowledge, honestly, of both care teams and patients. Serving the community better, really reaching everybody in the community and not centralizing around certain clinics, but really reaching everybody. We saw that very clearly around COVID. Having a platform that can scale with you, so really have the ability to scale up and down, with pandemic waves or with any wave that the sinus waves of healthcare treatment, and just in general improve that patient experience and the care team experience. Really have that quick access to data and to health information. Very quickly, how we structured it together at Microsoft, we structured all our offerings around healthcare around what we call the Microsoft Cloud for Healthcare, with 3 scenarios that healthcare providers are focused on, like enhancing patient engagement, empowering health team collaboration, and improving clinical and operational insights with specific capabilities. And what I want to double down on is the care team collaboration, because I think that's kind of the essence of where we can think how to empower care teams, as was mentioned in several in the video and also in the previous talks. So if we know that healthcare providers are recognizing the need for a more patient-centric approach, right, then we need to make sure that the care management approach fits that capability. So you want to make sure that we have the unique approach, the unique digital tools, the unique solutions to enable the patient-centric approach, but that we are absolutely empowering and enabling collaboration and tools to make the care workers work better together. So what I want to present is a few challenges and how we think, we can, the challenges that we see that care teams are facing. So challenge number one is that care teams lack a secure communication channel for collaborating and coordinating care delivery. So in a hospital, it takes between 10 to even 25 people to take care of one patient. These people need to sit together, consolidate their thought, their thinking, and discuss it. If the challenge is that there is a fragmented healthcare communication system and there's a lot of waste of time and money, so the solution is to unify that, to use a digital tool to unify the care teams and have a single communication platform to allow them to communicate there, but also, have that access to the digital health records, to the electronic healthcare records, to have access both internally and externally. And just think, a care team, is discussing together, and they can consult an external expert that is sitting, thousands of miles away, but helping them immediately. So these digital tools really, create that, small village of expertise that we can help care teams with. Second challenge is that too many. Yes. Okay. So that care teams lack a connected resource and system to coordinated care across multiple locations, across multiple providers, and sometimes across multiple specialties, I would say. So if we, again, unify that, have a real-time patient view, right? Consolidated patient view, an interface, a single interface for everyone. I mean, this is like very visionary. I know we're all thinking about our healthcare systems and we're like, oh, no way, right? But yes, I mean, we do see that governments and ministries of health and hospitals and care providers, they understand that when you have that unified approach, that single interface, the place where all the information is consolidated into one place, it really empowers the care and it makes everything more efficient. So care coordination, improving patient experiencing, that complete view of the patient, all those, would accelerate the care by minimizing the overhead that is involved with it. And finally, I would say the last challenge would be that providers really struggle to monitor their patients outside of the clinical setting. So you see a patient, but we're missing that continuous care, right? So you don't want to just see your patient when they're there. You want to make sure that they're taking care of themselves all along. So connecting that with what we call Internet of Medical Things, home care together with hospital care and clinic care, and consolidating everything into one consolidated view and consolidating the data from all these different data sources into one consolidated view. So care teams can save time, improve care quality by really streamlining workforce and streamlining tasks so that they have an easy to use coordination, remote monitoring, even resource scheduling. So any collaboration tools that we can help them with in order to help them work better. So that's how we see our approach to healthcare workers. If I talk about what happens at Microsoft, so when the pandemic hit, we moved to a home office immediately. We all use Teams, exactly what we're using now. So for us, the meetings over video and over calls was natural. All in all, okay? When we thought about, and like I said, our mission is to empower every person and every organization on the planet to achieve more. So, when we think about, our home and our, us as employees, how can we make sure that we are still working, we are still, efficient at work, but also that we're really taking care of ourselves and that we really have the ability to take care of our families. So, so we realize that our principles that we use on the everyday life, really they're continuing to guide us through our decisions throughout, how we respond to the pandemic. So first of all, one important guideline is to maintain the physical, the mental and emotional safety of all our employees. That is has been one of the most important aspects of any decision and any guideline we take. Second is supporting the employee needs to offer flexibility, right? So we offered leave time, paid leave time. We offered, flexibility, like everybody knew, that you can work wherever you need. And, if you need to do homeschooling for your kids because they were home, on their remote devices, and then to work in the afternoon, everybody understood that immediately. We all got used to seeing our kids, our cats, our dogs, like climbing on us through our work environment. And it actually made us a lot closer. Right? If before every such meeting was very formal and very, we need to make sure that there's no noise, everything opened up. We were people. And we were people also with our customers, and the needs, the emotional needs, the challenges we dealt with, they were there. And it made everything much more real, flexible, and copable. We were able to cope better. Another guideline was to help our customers to continue the critical business operations, right? Not all customers and not all partners and not all the customers that we work with have this setup. So we helped them to adapt to that really quickly, to set up the right setting to work remotely. And finally, also make sure that we are meeting all the regulations and guidelines, and that was very important. So what happened a couple months ago is that we realized that we want to announce this hybrid workplace as something that we will continue to work by. So the hybrid workspace in the pandemic is 6 stages of how we work, how open or closed an office can be in an area. But the main thing about it is that as an employee, you can choose how much you want to work from home, how much you want to work from an office, even when everything will be open. And that is the most important thing, because you as an employee, you feel empowered to take your own decisions, to make your own priorities, and to still give the best to your work. So with that, I want to end, and I want to really thank you very much for this great discussion. And maybe I'll end just by asking you or having you think, how will you revolutionize healthcare? How will you revolutionize the way people work in your company? And how can we all make this world just a really better place, but a much more consolidated place to live in? So thank you very much.
Ruthie,
Yes.
I am manning the barricades myself for that revolution. Thank you very much for your contribution. I know you are pressed for time, so I'm going to quickly fire a question at you, if I may. You're literally running out the door to feed a cat or a child. I'm not sure which, or dare I say, continue working.
Continue working, yeah. Child is after.
What have we learned from COVID-19 and lockdown that could be turned into an advantage, would you say, for smaller countries, especially Central and Eastern European countries that lend their workforce, that train up all these nurses and doctors, and then they go off to wealthier countries in Western Europe? Is there anything that we've learned from all the data that you've been talking about, data management, that could be turned to an advantage for Eastern European and smaller nations?
Absolutely. I would say the key to it is collaboration. Because I think we can collaborate across data, and we can use data across health systems, across countries. We used to be very siloed in our approach. Of course, we share information across health organizations, but really sharing data and leveraging the power of the collaborated and consolidated data to make decisions and to interact with each other, and to make clinical decisions, and also collaborate across countries for expertise, right? So yes, there is a mobility of workers. So we can today we see. We have an example of Mount Sinai performing an operation with HoloLens with Ugandan doctors. And wow. I mean, I'll share this video, and it's so powerful to see this, that really they're operating at the same time, simultaneously, and the Ugandan community is enjoying the expertise of the Mount Sinai, New York City expertise. So that's what the pandemic brings, I think.
Fantastic. Okay, Ruthie, I know you're rushing off. Thank you very much for joining us. Please share that video with us, and we will put it up on the EIHSD.eu website. You can move on now, Ruthie. I know you're a busy lady, and I am now going to go to Dr. Markus Schneider to say a few words. Markus is a longtime friend of the EIHSD and has given already a number of interesting presentations. He's the director of the Basis Institute in Augsburg, and he's going to talk about the multi-regional response from emigrating countries and receiving nations. Dr. Schneider.
Joe, thank you. Thank you for the possibility to share some ideas on hybrid workforce simulation and bringing together on a macroeconomic picture connecting different processes in information. Now, what I would like to discuss with you are the first results of the health workforce mobility multi-regional input-output model, which allows to integrate national accounts data, health accounts data, and labor accounts data. Now, what is in the center now of my discussion are the relation between skill, disease-specific impacts, and income and working conditions. On a macroeconomic point of view, income and working conditions are described in the national accounts. Healthcare coverage are described in the system of health accounts by public-private financing streams, and skill and disease-specific structures are presently not in it. And that's what is now new in this presentation, that we can, by linking this information, show new structures at the macroeconomic level between European countries. I would like also to go short on COVID-19, although this is a very specific disease, and in the broader picture, what I now draw, not included or not really catched as a single element. And I think what's the most important point is, what are financing mechanisms to mitigate the net migration at the periphery of the European Union? Now, before we go into the details of the simulation, I think it's very important to have a general understanding of migration in Europe. And on the picture on the right side, you can see that there are 8 countries where the people during the last decade decreased almost 2 million, while in whole EU 27, we have an increase about 8 million, mainly coming from outside the European Union, but also some people from these 8 countries at the periphery. Now, if we discuss general or migration of health workforce, we have to be aware about these general migration structures, also because we are not always in a situation that we are able to separate these flows. So often from the statistical side, we are only able to see the results or the net migration flows. Latvia, Lithuania, especially Lithuania, faced the highest decline of population during the last decade, and then Latvia, Romania, Bulgaria. The results are income divergence and difference in employment opportunities, and a spatial divergence of the situation. Now, as I already mentioned in an earlier presentation, the challenge is for each country to bring together the input-output tables, the basic tools or the supply and use tables, the basic tools of national accounts, with labor accounts information across skills and disease accounts, which means an extended system of health accounts. This is one challenge. It's already a big challenge for each country to do that. For the immigration countries, for emigration countries, but in the middle of this slide, you see also the links, and that are linked to the 4 freedoms what we have in the European Commission, in the European area. That means free movement of goods, of services, of people, and of capital. And exactly if we want to simulate the situation in a macroeconomic model, we have to be clear how we describe the markets. Now, the result presently is that the 13% of people living in these 8 emigration countries have an income, a value added, which is below 6% of the total income, and compensation of workers even lower. It's only around 5%. That means that the per capita income, it's much lower in this area, in the peripheral area, than in the center. What we expect, if we would have a common equal distribution, that they have also 30% of compensation and value added. And if you look to healthcare, the situation is even worse. Health expenditures are around 5%. Health expenditure in the NACE sector, 86. Healthcare, it's a little bit higher than 5%, but below 6%. And what is really low are the health expenditures in the social sector and long-term care in these areas. What we can also say is that immigration countries invest less than immigration countries in healthcare. And as a result, health employment is also lower. Now, what is very interesting to see, if we link this information to skill-specific effects of migration, that of the 1.9 million persons working as doctor in the health sector, the distribution is more or less. It's certainly there are different and very different distributions within across countries. But if we look on the two regions, then we see that in the group countries B, the immigration countries, the average number of doctors per person or per inhabitant is even in the median a little bit higher than in the immigration countries. But the opposite is for nurses. In nurses, we have substantially less nurses in the immigration countries, and the situation is even more worse concerning other health professionals. Now, the question was now how to link this information to diseases. And I have summarized this in an aggregate way, linking information from the project of HEDIC, health expenditures by disease, with the skill structures and national accounts information. And here we can see now the distribution in this group of 8 countries across different types of ICT chapters. So in others are included particular gynecology, but other symptoms, chapters like congenital findings, symptoms, pregnancy I already mentioned, perinatal symptoms. So it's a very broad area. Most, I think, 35% about of the workforce is really mainly included in that type of diseases. Then ST means the disease, the chapter injuries. This is very small, and I was really wondering why it's so small, but the data included here are not really from all 8 countries. They are from Lithuania, Latvia, Estonia, Bulgaria. So they are limited in some way because we have not all countries in it. But on the other side, it makes also sense if you look it to other figures. The chapter M is musculoskeletal diseases. K and E are diseases of the digestive system, of endocrinical diseases, and of the genitory system. And I are the heart diseases, circulatory diseases, which are usually always a big chapter in not only in mortality, but in healthcare treatment and in the allocation of resources. Then F, G are mental diseases and of the nervous system, and C, D are neoplasms. Now, and on the left side, I have described here the basic equation, how we are able to link this information. And what I found very interesting, and what we just remember on that, what Ruti Kaider mentioned, it's really necessary to connect the information by for each type of process. So we're looking also on more or less on a macroeconomic view on processes or activities, and analyze and the technical situation to link that. Now the condition matrix V are from the HEDIC project. It's described the health expenditure by disease. G describes the health expenditure vector account functions or healthcare providers, and RIG then the result, the health workforce by skills and conditions. Certainly there are some assumptions behind that, but these assumptions you have also to bring it in, for example, in the World Health Organization's approach about measurement of health shortages. Now, this approach, what I propose here, gives you, I think, a much more detailed picture about the situation and of the analysis of shortages. And I will contrast now this data with the data of the immigration countries. And if we contrast this with the immigration countries, then we see very interesting results. We see, for example, immediately that in these 8 immigration countries, we face a shortage in the treatment of FG. That means in the mental, related to mental diseases, long-term care, nervous systems. And what type of skills we miss? Now, this analysis is very rough and not very detailed, because in detailed information we should distinguish then between psychiater, psychotherapist, and so on. We have not done this here. It's a very rough picture, but however, I think it makes sense really in relation also to other studies which are going, particularly studying the situation in brain disorders and so on. We measured here just about 500,000 people, say, and the standards of the immigration countries. In the emigration countries should be about 500,000 more people employed. The most are not doctors and nurses, but other health professions, technical professionals, other professionals. Okay, this is a standard of the immigration countries. It's not a general derived disease-specific standard by medical professions. But it gives you an idea about the size of this of this shortage, and it's now possible with this information to make further analysis to measure the direct income losses and gains of this situation, because in fact this shortage manifests the migration of this type of people into the other countries. long-term immigration always means a loss of income for the immigration countries, but a positive income situation for the immigration countries, and negative for the immigration countries. And I found it in the last webinar very interesting from Dr. Oletsky, where he emphasized the short-term immigration, because only the short-term immigration might lead really to a win-win situation for both country groups. And this can be now in a model with quantified, one can show the total income effects and also the special effects for the country groups. The problem is that the negative effects in immigration countries leads to a financing problem in healthcare and less investments. And that means negative impacts on the working condition, because material is not available and equipment is not available. And if one looks at the capital stock per capita in the health and social care sectors across these two country groups, then you see a much lower, on the right side, capital stock and capital use per capita in immigration countries. Countries of Group B invest less than countries of Group A. The capital stock is roughly 4 times higher as in the immigration countries. And capital intensity difference is still twice as high in Group A as compared to Group B. Now, what I found also interesting, if I now say shortly something to COVID-19 impacts, this is really on the macroeconomic view, but on the macro level, we see between the two country groups not a big difference really in the incidence rates and on mortality rates. And on average, not on the median, but on average, lethality, it's a little bit higher in the countries B, but I think it's very difficult to say something presently about the causes of these differences, and to say maybe lower IQ capacities or hospital capacities have contributed to that. I was just wondering when I saw this picture from Vitenis about the negative correlation between extra mortality on the one side and health workforce density, that maybe the effects are stronger on the side effects, and it's necessary. And that's one of the reasons why we need a health union, that we cannot only focus on infectious diseases, but we have also to look on chronic diseases and to see really the interaction between the processes. What's also interesting is that the growth impacts and the median income losses in emerging countries are not higher.
I'm so sorry to interrupt your presentation, but I'm going to ask, if I may, Vitenis to give his closing thoughts before he rushes off to a TV studio to do an interview. If you could unmute yourself, Vitenis, and then share your closing thoughts, and then we can move on to Birute.
Sorry, I would like to say that it was Marco's presentation was so important, and now we have a lot of food for thoughts. and especially now keeping in front ideas about European Health Union, about healthcare workforce shortages, about really situation which can it's call us to action. Now we see COVID is a tragedy. Countless lives have been lost, including those of workers in the health sector. Passed away due to workplace accidents, and occupational health and disease are a very, very sensitive issue. As you know, it would be commemorated on 28th of April. And COVID-19 is an awakening call for many of us. And I would be more than happy to say that we need to now to conclude our webinar and to present our conclusions in more detailed way, keeping in mind all our speakers, including Marcus, Sergei, and Ruti. And of course also Birute. And ongoing discussions on European Health Union are interrelated with debating of pan-European solutions of healthcare mobility. On one hand, a strong European Health Union is background of coordinated policies of healthcare workforce mobility. On the other hand, the deeper understanding of international health workforce mobility provides evidence-based arguments for the architecture of the European Health Union. And let us hope that the conference on the future of Europe that will start on 9th of May will prioritize health and European Health Union as a main new, page of evolution of European Health Union, of European Union as such, because European Union was built on steel and coal agreement. Now European Union must be developed based on quality of life, on well-being, on healthy conditions and possibilities to prevent people from infectious and non-infectious diseases. And next webinar from our series is planned for the end of June, with an emphasis on pan-European health personnel policies as one of the main pillars of the European Health Union. And our voice should be heard, and we can invite all our partners, all our NGOs, academia, and so on, to now, like never before, to join our forces and to press very much, our governments and national parliaments to include European Health Union topics into the agenda of European Health Union, and of course, to be brave. We need changes in the European Lisbon Treaty. No doubt, without changes, EU will never address issues related to people, health and well-being.
Thank you, Vytenis, and best of luck in that TV interview. I'm sure you will knock it out of the park, as they say in America. I'd like to invite Birute Tumieni from Vilnius University Hospital, also known as Santaros Clinic, to join us now. So Birute, I see you've got a presentation ready to roll. Birute will be talking about the trends in Lithuanian medical schools before and after COVID-19. If you could unmute Birute and fire ahead.
Thank you very much. Can you hear me?
Yes.
Yeah, so good day. It is really my great pleasure and honor to be here among you. And thank you for nice introduction. And during the subsequent 10 minutes, I will talk about international student mobility as a very early form, actually, of migration, healthcare workforce migration, and brain drain or brain gain. And here I'm representing Vilnius University Faculty of Medicine, where I'm lecturing all first-year medical and odontology students and sixth-year medical students and also advanced nursing students. And we have both international and national courses. So, sorry for that. Actually, the number of students enrolled in tertiary education outside their country of citizenship has sharply increased over the recent decades, reflecting the expansion of tertiary education systems worldwide and globalization from roughly 1.3 million worldwide in 1990 to 5.6 million in 2018. And the usual destinations are, of course, developed, mostly English-speaking countries as UK and USA, and also non-English as Germany and France. And actually, as I remember from the days of my studies, approximately 10% of my course actually headed for these countries some 20-25 years ago. When my daughter, 20 years later, graduated from Vilnius Lyceum, that is ranked as #1 school in Lithuania for a number of years, for several decades, her peers that chose medicine also headed the same directions. And as you can see from this slide, Lithuania is among the countries that with the highest shares of national tertiary students enrolled for studies abroad. And also our share of international students increased from roughly 3% in 2014 to 5% in 2018. We are among those net exporters of students. However, at the same time, by lecturing in my university, I know very well that our numbers of our international students grow every year. We started to provide first degree studies in medicine in 2011 and in odontology in 2014. And actually the only thing that limits international student numbers are quotas introduced by our own university, because we do not have state regulation of international students, only nationals. And I know very well that we have by far the highest share of international students in Vilnius University, that actually encompass 12 faculties in various studies. So actually we have 2 medical schools in Lithuania, and the trends in the second one during the recent years are absolutely the same, with growing numbers of international students. Remarkably, we are not exceptional, actually, in this regard among Central and Eastern European countries, so-called newcomers in EU. And if we rank countries according to the share of tertiary students in the field of health and welfare studies, countries like Bulgaria, Slovakia, Romania appear in the first ranks, and actually many others are also considerably above EU 27 average, among usual suspects as Ireland. So also global student mobility mirrors inter- and intra-regional migration patterns to a great extent. Actually, in the field of healthcare and welfare studies, we can see stunning exceptions. So what is going on in the market of medical education in Europe? If we are aiming to understand the phenomenon, we need to find out what is pushing or pulling these students to choose their destinations for medical students. Traditionally, attractiveness of a country or educational institution was largely determined by the prospects of improvement of employability, getting closer to labor markets. Also, for some countries, political stability, European values, and what eases transition are cultural and religious similarities. However, recently, financial factors, Bologna process that results in recognition of medical diplomas across EU and EFTA countries, and globalization, also active recruitment, are of increasing importance. By studying carefully the origins of our international students in our university, I tried to understand the motivation behind their choice, and to ask questions like, do we attract neighbors? Almost not. Is it due to the lack of access to those students at home? Possibly, highly likely actually. A new trend is that for these students from developing countries, our countries are usually an intermediate stop to complete first degree medical students studies before heading for the desired eventual labor market. But what impacts most motivation is actually Bologna process, and also globalization of medical education in countries like Israel that also acknowledges Lithuanian medical diplomas. These students usually fail to enter medical schools at home and come for paid studies. Sometimes these payments exceed 15 times those for nationals, for example. So what is also characteristic for these countries that they cover at least partially studies for their nationals abroad, and they have expanded internship and residency admissions to accommodate foreign trained nationals. So actually stay rates among our international students are almost zero. After completion of their studies, all of them go out. Of course, money matters everywhere. And when you may get MD diploma in Romania for 10 times less than, for example, in Ireland, it of course matters. And subsequently, there is a recent trend of growing shares of foreign-trained natives among a healthcare workforce in a aforementioned country. And for example, recently in Norway, the share of foreign-trained natives is higher than foreign-born healthcare force, and it is a new trend. So we will see eventually will it diminish physician migration in the coming years. Now let's have a glimpse at the life of these students. All of them, they are subject to really huge acculturative stress. It is a well-known phenomenon due to a higher level of stress, reduced quality of life, loss of social contacts, cultural, religious barriers. And in our university, we try to support our students. You can see here, we have rising numbers of Finnish students that get social support from the faculty, but also established the peer support group that actually joins now more than 1,100 Finnish medical students studying abroad. That acculturative stress, of course, have its impact on academic performance, and it was proven in several studies. Also, we can see results from our faculty that these internationals, they usually perform worse. And for example, in France, it was performance of students entering second-degree studies in national medical examination. Most of them were trained in Romania, was very significantly worse than those of nationals. So indeed, no wonder that recently a member of European Parliament from France raised some uncomfortable questions about these practices that were also fueled by a alarming incident when 6 interns were dismissed from hospital in Ile-de-France due to unacceptable lack of competencies. Luckily, in Lithuania, we really apply high standards of conduct towards both nationals and internationals. However, I really understand my university when I look at diagrams as this one, and I know very well that Lithuania spends the lowest proportion of its GDP on educational institutions. Moreover, this proportion is even diminishing in recent years. We are also anti-champions in this regard. Mm-hmm. So recent pandemic was really devastating for all higher education institutions, but of course also for our international students due to safety legal issues, due to online training, but also it raises some question for these students. Will they have intention to head for those labor markets, usual labor markets, when some education is provided online? So in conclusion, with novel players in the educational market, we have several scenarios across Europe. For developed countries, it is a way to increase access to relatively cheaper medical education services with no need to expand educational services at home, and opportunities for those who fail to enter medical studies at home. for countries like Romania, who actually diminished admission rates for their nationals, it raises questions about equity in education, actually, and we are somewhere in the median between these extremes, countries like Lithuania or Poland, because we take care about our nationals, but nevertheless, we are still net exporter of national students, and we provide those relatively cheaper medical education services for some EU EFTA countries. Hence, as a final word, I would like to say that I try to share that optimism and belief in bright future with my students, and would like to thank you for your attention.
Ačiū, Birute. Thank you so much for your time. I wanted to ask you a load of questions, and I wanted to put a few to Marcus and Vitan as well. Unfortunately, we have run out of time. I need to wind up the panel discussion and bring things to a close. I'd like to thank our incredible participants today, Dr. Marcus Schneider from BASIS in Augsburg, Sergejus Glovashkus from the ILO in Geneva, Ruthie Kaider from Microsoft in Israel, Birute Tumieni from the University of Lithuania in Vilnius, and of course our chairman Vytenis Andriukaitis. Stay tuned for our next webinar, which we hope will be in June. It'll certainly be before the summer holidays. We'll be uploading the video for today's session on the website eihsd.eu. So stay tuned for that, and you can have a listen to all the presentations we've had today, which we will also be uploading. From us, from me, Joe Lynham in London, stay healthy, stay well, get your vaccine in your arm, and we will see you next time. Goodbye.